So next is a rectal prolapse. It's a V14. You see a 28-year-old male who presents a clinic with a history of chronic constipation. He's now complaining of an intermittent lump PR, which he notices when he defecates and is causing him discomfort. He says he is able to reduce the lump himself. What else do you want to know? So I want to take the history about his red flag symptoms. Red flag symptoms are 4 or 5 questions: recent change in bowel habits, unintentional weight loss, unexplained iron deficiency, anemia, bleeding per rectum, and constipation score Rome criteria 4. If 2 or more than 2 present, then they met the Rome criteria for slow transit constipation, and the Rome criteria includes number 1, 3 bowel free movements in 1 week, and 25% of the time they are straining, and hard or lumpy stools, and they have a sensation of incomplete evacuation, and they have a sensation of some blockage, and they do some maneuver to remove the stools, and stools are not diarrhea due to the laxatives. This will be loose only because of the laxatives, and rule out the IBS. And then bowel frequency and consistency regarding the Bristol stool chart from 1 to 7: 1 constipation, 7 diarrhea, and history of straining, obstructive defecation syndrome, and digitation, and then laxatives treatment to date, and exclude the secondary causes of neurogenic, endocrine, metabolic, anatomical drugs, and consider Hirschsprung in young people. Examination: sphincter tone, evidence of anismus, rectocele, perineal descent, proctoscopy, piles, solitary rectal ulcer, radioscopic interception, and prolapse. You strongly suspect the gentleman has a prolapse. How else could you examine him? So I would examine him on the couch in the left lateral position and ask him to strain. Me demonstrate a prolapse, as this is not a standard defecation, so I would examine the patient on the toilet. I would examine the prolapse to determine if it's a high takeoff or low takeoff. To determine which surgical procedure to do this, I would slide my finger up the side of the prolapse to identify the lead point, and then sitting him on the toilet demonstrates a full thickness circumference rectal prolapse. How do you proceed? So I would organize in some investigation which would include a flexible scope to pathology. I would organize the endoanal ultrasound to assess this after having a long-term prolapse. If I was concerned about Hirschsprung as the cause of his constipation, I would arrange an rectal manometry and physiology, including rare test, that's rectoanal inhibitory reflex. If this is a high takeoff prolapse, I would consider a proctogram, which would assess for interception and enterocele. And as the patient is young, I would want to rule out Ehlers-Danlos syndrome, anorexia, history of chronic constipation, and ask about sexual history and history of abuse. What are your options for treating this man? So first, exclude any underlying medical cause of his constipation. Dietary advice, including dietitian referral and laxatives. Lactulose shown in randomized trial to cause higher bowel frequency and improve stool consistency consistent with fiber. Fiber excess can cause severe bloating. If suspect Ehlers-Danlos syndrome, referral to the specialist unit. If suspect anorexia, referral to the specialist help and psychologist. And if transit study, if through transit prucalopride 2 milligram per day for 4 weeks trial, in view of the fact that he suffers with chronic constipation, I would refer him for biofeedback to address his underlying functional assess tissues to reduce his risk of recurrence. So rectal irrigation may help this in constipation. If biofeedback fails, a gastrograph and enema could be used to assess for redundancy. I would also counsel the patient about surgical repair. So this patient has 2 issues: rectal prolapse and constipation. So we have to be very careful. So for constipation, we have done the laxatives, diet therapy, and biofeedback, and then irrigation as well. What are your surgical treatment options for this patient? Treatment options would depend on whether this is a high takeoff or low takeoff prolapse. A high takeoff prolapse is best addressed by an abdominal approach. For a low takeoff prolapse, options include perineal approach, DeLorme's and Ultimate, versus abdominal approach, rectopexy, posterior suture versus ventral mesh. What would you pick for this patient and why? The Prosper trial showed no difference in recurrence rates between all the approaches for prolapse, with rates of recurrence from 13 to 24%. All approaches showed a substantial improvement in the quality of life post-operatively. The Prosper trial did not classify the type of prolapse into high or low takeoff, and the surgical option was based on surgeon's choice. The abdominal approach carries the risk associated with pelvic dissection and potential nerve damage. If a mesh is used, there are Reports of chronic pain and potential mesh erosion of posterior suture rectoplasty had been reported as causing an increase in constipation postoperatively, but more recent studies looking at preservation of the lateral ligament suggest this may not be the case. What would you say to this patient preoperatively? So risk recurrence is high if the underlying condition is not addressed. Needs biofeedback pre and post op to get the best effect. Number one. Number two, no evidence to suggest which repair is best. Number three, MR only addresses the anterior portion of the prolapse. Number four, posterior dissection risk of nerve damage. Number five, perennial repair low risk but higher chance of recurrence. Thank you.